Welcome to The Explainer. Today we are tackling one of the most fundamental and, let's be honest, sometimes confusing topics in medicine: fluid and electrolyte disturbances. My goal is that by the end of this, you'll have a super clear roadmap to navigate these common problems on the wards.
So let's just jump right in with a classic scenario you will see constantly. You get a page, a lab alert pops up, your patient's sodium is 125. Now, the knee-jerk reaction might be, oh, they need more salt, right? But is that actually what's going on? That simple number hides a ton of complexity, and the absolute key, as you're about to see, is understanding that this is almost never about too little sodium. So here's our game plan. First, we'll cover the body's fundamental balancing act. Then, we're going to dive deep into low sodium, hyponatremia, and its opposite, high sodium, or hypernatremia. After a quick primer on potassium, we'll pull it all together into a practical diagnostic framework you can use right at the bedside. All right, let's get into it.
First up, the body's balancing act. And I really want you to pay attention to the subtitle here: why your body cares more about saltiness than volume. Because if you can truly grasp this one physiological principle, I promise everything else we're going to talk about is going to click into place.
Okay, so here's the deal. Your body has two totally separate, though related, systems for managing water and sodium. Water balance, that's all about keeping the saltiness of your blood, the osmolarity, perfectly constant. And that's controlled by thirst and a hormone called ADH. Sodium balance, on the other hand, is all about keeping the pipes, your blood vessels, full enough to maintain good blood pressure. And that's the kidney's job. So remember, two separate systems, one for saltiness, one for fullness.
And the way this works is actually pretty brilliant. When your brain senses your blood is getting just a little too salty, it shoots out that hormone, ADH. ADH then goes down to the kidneys and basically acts like a key, unlocking these tiny water channels. This lets your body pull pure water back from the urine before you pee it out. The result? Your blood gets diluted back to normal and your urine gets more concentrated. It's an incredibly elegant system.
Which brings us to the single most important concept of this entire explainer. Seriously, if you walk away with just one thing, let it be this. I'm going to say it again. Disorders of sodium concentration are almost always disorders of water balance. So from now on, when you see an abnormal sodium level, your first thought shouldn't be, what's wrong with the salt? It should be, what is going on with this patient's water?
Okay, so with that core principle locked in, let's apply it to our first clinical problem. We're talking about dangerously low sodium. It's time to decode hyponatremia. So by definition, hyponatremia is a sodium level below 135. But that's not the important part. The important part is the cause. It's almost always from too much ADH, which makes the body hold on to water, or less commonly, from just drinking way more water than the kidneys can handle. So let's be crystal clear. Hyponatremia is not a sodium deficiency, it's a water excess problem.
All right, you've got that low sodium lab result. Where do you even begin? I mean, the list of possible causes is a mile long, right? Well, the good news is there's a system, and it all starts with one simple question that you can answer just by examining your patient.
And this flowchart shows you that critical first step. Before you even think about ordering another test, you have to assess the patient's volume status. Put your hands on the patient. Ask yourself, are they dry, dehydrated? Are they swollen and overloaded with fluid? Or do they seem just about right? This single assessment is the most important decision you will make.
And once you've done that, you've basically sorted all the possible causes into three big buckets. If your patient is hypovolemic or volume down, you're thinking about things like diuretics or GI losses from vomiting. If they're hypervolemic, swollen with edema, your brain should go to heart failure or cirrhosis. And if they look euvolemic, they seem to have a normal amount of fluid, that points you toward a very specific and really common syndrome.
For those euvolemic patients, the big diagnosis to consider is SIADH, the syndrome of inappropriate ADH secretion. This is just what it sounds like. The body is releasing ADH when it shouldn't be, causing it to retain a bunch of water. And as you can see from this chart, the causes are all over the map, anything from brain and lung diseases to cancers to a whole laundry list of common drugs.
Now, I have to pause here for a critical warning about treatment. This cannot be overstated. If you correct a patient's sodium level too quickly, you risk causing a devastating, permanent neurologic injury called osmotic demyelination syndrome. So the rule, always, is go low and go slow. Please, never, ever forget that.
All right, let's flip the coin and talk about the opposite problem: dangerously high sodium, or hypernatremia. If low sodium is a problem of too much water, you can probably guess what this one is. It's fundamentally a problem of not enough water.
So hypernatremia is a sodium greater than 145. And what that really means is that the body has a water deficit. It's lost more water than salt, and now the blood is too concentrated, too salty. This usually happens in patients who can't access water or can't express that they're thirsty. Think about infants, confused elderly patients, or anyone on a ventilator.
And what's our approach? Well, you're probably sensing a pattern here. Just like with low sodium, your very first step is to get to the bedside and assess the patient's volume status. Your physical exam is, once again, the key that unlocks the whole diagnostic puzzle.
Okay, we've focused a lot on sodium and water, but let's shift gears for a minute because there's another electrolyte player we absolutely have to talk about, and that's potassium. Problems with potassium are super common, and fixing them correctly goes way beyond just ordering a banana bag.
Hypokalemia. That's a serum potassium below 3.5. And you've got to respect this one. Low potassium isn't trivial. It can cause everything from muscle weakness to outright paralysis, and most scarily, it can trigger life-threatening cardiac arrhythmias. It's one of the most dangerous electrolyte abnormalities you'll face.
So where does all the potassium go? Well, this table breaks it down nicely. Sometimes it's just a redistribution issue. Meds like insulin or albuterol can temporarily shift potassium from the blood into the cells. But more often, you're looking at true losses, either from the GI tract, like with diarrhea, or from the kidneys, usually thanks to diuretics. And check out that last one. A low magnesium level can actually make the kidneys waste potassium. Keep that in mind.
Phew. Okay, that was a lot of physiology, I know. So let's pull it all together. Let's distill everything we've talked about into a simple, memorable framework that you can take with you and use every single day. Here it is, your 3-step bedside roadmap for any sodium disorder. Step 1, assess volume status first. Always. Is the patient dry, wet, or just right? That's your first big decision. Step 2, check the urine electrolytes and osmolarity. This tells you what the kidney is trying to do or what it's failing to do. And step 3, once you have a cause, correct it, and please correct it slowly. Follow these 3 steps and you'll navigate the vast majority of these cases with confidence.
And we'll leave you with one final, crucial clinical pearl that ties a few of these ideas together. When you have a patient with low potassium, before you rush to give them a bunch of potassium, there is another electrolyte you must always check and fix first. What is it? It's magnesium. That's because the channel in the kidney that reabsorbs potassium needs magnesium to work properly. If the magnesium is low, you can give potassium all day long and the patient will just pee it right out. It's a perfect, humbling reminder of how beautifully interconnected all of these systems really are.